policy and law, both domestic and international. Jennifer is also leading Healthcare Canada's efforts to level the playing field between physical and mental health. We're very pleased to have her with us today. We will also have speakers from the Michael Garron Hospital, which is part of the Toronto East Health Network, and also formerly known as the Toronto East General Hospital, which I personally have trouble making the switch, but hopefully after today's presentation that will help all of us. Wilf Clausen is the Vice President of Program Support, who is responsible for a variety of clinical and corporate areas, including but certainly not limited to human resources and organizational wellness, quality and organizational safety, and volunteer. In addition to his impressive credentials, Wilf has also is an adjunct appointment at the University of Toronto Department of Health Policy, Management, and Evaluation. And joining Wilf is Christine Devine. Christine has over 20 years of experience in the fitness and wellness industry. Christine is a wellness specialist, and she is proudly refers to herself as the Chief Motivating Officer of Michael Garron Hospital. She is an emotional intelligence instructor and compassion fatigue facilitator. Welcome, speakers. So now just quickly, I want to just go over very quickly the focus of today's webinar, which is first with Healthcare Canada to give an overview of what they're doing, largely in collaboration with us at the Commission, to advance workplace mental health and healthcare settings. We will then hear from Wilf and Christine at Michael Garron Hospital about their journey in implementing the national standard for psychological health and safety in the workplace. And at the end, as time permits, we will be able to answer some of the questions, and again, using the chat feature as you can. So to get things started, I'm going to turn things over to you, Jennifer.
To be here on behalf of Healthcare Canada, and with my co-presenters, Wilf Clausen and Christine Devine of the Michael Garron Hospital, Toronto East General Hospital. I'm delighted to see that so many people have joined us here today. It really speaks to the level of interest in this topic. Healthcare Canada, as many of you know, is the national voice of Canada's hospitals and healthcare organizations. We're the result of a merger of CHA, the Canadian Hospital Association, and ACAO, the Canadian Academic or Teaching Hospitals. We have an 85-year history, and we merged into Healthcare Canada 2 years ago. At Healthcare Canada, we're committed to doing everything we can to level the playing field between physical and mental health, which we all know is long overdue. And of course, working in partnership and collaboration is essential to achieving this. We're very proud of our partnership with the Mental Health Commission of Canada. Our partnership with the Commission began almost 3 years ago. At that time, our Board of Directors passed a powerful position statement on psychological health and safety in the workplace for healthcare settings and called on all healthcare institutions to adopt the standard. At that time, the Commission and Healthcare Canada immediately recognized the synergies and potential that could happen from working together, as we say, the power of partnership. And I will say at this point that the Commission and its excellent staff have been an outstanding partner. So next slide, please. Why is workplace mental health so important to Healthcare Canada? Well, as an organization representing hospitals and healthcare organizations across the country, we know that this is an important issue for our members. We know, for instance, that employees at our institutions are 1.5 times more likely to be off work due to illness or disability than people in other sectors. And I don't think this will be news to anyone on this webinar that healthcare can be a particularly challenging environment, with heavy workloads, cutbacks, and layoffs, and people just generally doing more with less. Burnout is a very significant issue for health professionals working in our institutions, and there's some stats that are before you. A 2011 study found that 14% of general nurses have tested positive for symptoms of post-traumatic stress disorder. Workplace violence is a growing and sometimes neglected issue. A 2016 study found that 46% of nurses reported workplace violence during their 5 most recent shifts. Also, the very nature of work within our institutions, helping patients and families cope with illness, can result in what's called compassion fatigue. Exhaustion and sleep deprivation can negatively affect the delivery of care. Next slide, please. Stigma. So we know that stigma and discrimination around mental health is a significant issue in the health sector, like everywhere. Indeed, 60% of people with mental health problems won't seek help for fear of being labeled. And this is not only the stigma experienced by people who require care from healthcare workers and professionals, but also the healthcare workers themselves who struggle with mental health issues. Next. Many of you will be aware of the standard, the Psychological Health and Safety in the Workplace Standard. It can be downloaded at the link that's before you. The standard has been downloaded over 25,000 times, which for a standard is a very significant number. And we know that 20% of these downloads are by healthcare organizations. So clearly there's an interest and appetite in the healthcare sector. We know that good psychological health is essential to being an effective healthcare worker. So a mentally healthy workplace can improve morale and relationships. It can boost productivity, improve recruitment and retention. It can improve patient satisfaction. It can lead to a reduction in absenteeism and turnover, a significant issue. May lead to a reduction in healthcare costs, and it may also lead to a reduction in medical errors. And we also know that steps can and are being taken that will make a difference to the workplace's workers by many people who are on the line today, and the leadership among the participants on this webinar. And also we'll hear from Wolf Klassen and Christine Devine from the Michael Garron Hospital, Toronto East Health Network of the outstanding work that they're doing. Next. This is just a quote from our position statement that I referenced earlier that speaks to further advantages. So in terms of productivity, financial bottom lines, we know about return on investment, but also the issue of recruitment and retention. Increasingly, talented employees may be attracted to companies where mental illness and mental health can be talked about openly. So as stigma decreases in our society, being more open about mental health and mental illness may be something that's expected from employers. Next. I'm going to speak briefly to what Healthcare Can is doing to advance workplace mental health. And as Sandra mentioned, we're doing a lot of this in partnership with the Commission. As I mentioned, we released a position statement 3 years ago, which was focused on the healthcare sector and strongly encouraging members and all health system stakeholders to adopt the standard on psychological health and safety in the workplace. Many of our members have adopted the standard, and many of our members are leaders in this area. Leadership is an area of focus for Healthcare Can, and our position statement certainly underscores the importance of leadership. We also co-host a national health leadership conference each year. We co-host it with the Canadian College of Health Leaders. This is the largest gathering of health leaders each year in Canada, and over the last 2 years, we have worked to raise the profile of mental health issues, including workplace mental health at NHLC, which is not to say we didn't profile it in the years before that, but certainly in the last few years we tried to elevate that emphasis. Healthcare Can is also an advocacy organization representing hospitals and healthcare organizations, and we advocate for health system transformation. We do so both on our own and also in coalition. For example, with respect to our coalition work, we're a very proud founding member of CAMI, which is the Canadian Alliance for Mental Illness and Mental Health. And part of our advocacy messaging over the last few years has related to encouraging the federal government to adopt the standard. We've also been advocating for an extension of the Commission's funding, Mental Health Commission's mandate. And I'm very delighted to say, not just our efforts, but efforts around the country, the federal government is taking enormous steps in terms of implementing the standard, really leading by example. And also, very happily, the Commission has received a 10-year extension to its mandate in the last budget. So we work in partnership in just about everything we do. We know about the power of partnership, and as I mentioned, the Commission as well very much works the same way. And as I mentioned, we've worked in partnership with the Commission to host 3 very successful roundtables across the country over the last few years in the West Coast, the East Coast, also in Central Canada. And we're also exploring other opportunities for engagement across the country. We've also done some research and established a community of practice, which I'll mention in a moment. And finally, we have an education arm at Healthcare Can, CHA Learning, and we've integrated psychological health and safety in the standard into our course curriculum where appropriate. Next. So I mentioned the 3 roundtables that we've had with the Commission. We brought together over 50 healthcare leaders at all levels, CEOs, VPs, directors, HR advisors, and managers, and so on. And from the roundtables, we learned a lot about some of the key enablers for implementing the standard. And Wolf and Christine will discuss some of these in their presentation. Leadership, for example, is key, a clear champion or leader. Also, we heard that data and metrics to establish baseline data and monitor trends is important. In terms of barriers, we know that healthcare is often a very challenging environment with budgetary issues and competing priorities. Also, sometimes organizations say they don't know where to start. One of the big messages that we heard at our roundtables is that often healthcare organizations are already doing a great deal that relates directly to the standard. And once they take stock, they realize that they're already well on their way. Other barriers include lack of awareness and lack of union support. Next. I also would like to mention the case study research project that we did in collaboration with the Commission. Earlier this year, the Commission and Healthcare Can worked with researchers at Simon Fraser University to conduct a cross-case analysis of health organizations that were participating in the Mental Health Commission's case study research project. So of the Commission's, in the case study research project, there's 41 organizations and 18 are in the health sector, so 45%. Now, healthcare, of course, is a large employer in Canada, but it also speaks to the need and the interest in the standard within the sector. Some of the findings in terms of the research are on the screen. Healthcare organizations are certainly progressing and implementing the standard, and we know that the sector has unique strengths and challenges. Implementation is varying. And if you're interested in learning more about the study, it's available on both of our websites. Next. Next slide, please. Most recently, Healthcare Can and the Commission have formed a community of practice, what we're calling a By Health, For Health collaborative, which is made up of 24 health leaders from across the country. So this community of practice includes organizations that have already formally begun to implement the standard and other organizations whose interest in implementation is emerging. This collaborative will be building on the learnings from our roundtables and from the cross-case analysis and aims to take the work to the next level, to be as useful as possible to those who are implementing the standard. So, for example, the group's going to explore if there's a need for tailored tools and resources for the health sector. We know that there are a lot of tools out there, but what specifically does the health sector need to support their work? This group will also be a reference and advisory body to look at systemic transformational change. For example, what's the link between Accreditation Canada standards or required operational procedures and the standard? There could be systemic changes, things that we might want to advocate for to increase uptake of the standard. And this group will also help to influence others in implementing the standard. Next slide, please. Finally, before I turn it over to Sandra and Wolf and Christine, I want to mention a joint issue brief that Healthcare Can and the Commission recently released on mental health, workplace mental health. So you'll see a picture of it before you, and it's available at our website. I think this brief very nicely encapsulates many of the key issues and a lot of the work that we have done to date, but it's a good overview of this issue and some of our work. It also has many tips for healthcare organizations to get started in this area. So with that, Sandra, I want to thank you once again for this opportunity to present on some of Healthcare Can's collaborative work with the Commission, and I'll turn it over to you, Sandra. Thanks.
Thank you, Jennifer. I must say that it has been a pleasure to collaborate with you and your team over the past 3 years, as you mentioned, over all of these initiatives, and we definitely look forward to continuing this great work for hopefully years to come. So I am now pleased to turn it over to Wolf and Christine to hear about their journey at Michael Garron Hospital with implementing the standard. They're participating in the Commission's 3-year case study project that Jennifer has mentioned, and they really are true champions in this area. So I'm now happy to pass it over to you, Wolf.
Share the journey that we've been on. And again, to start with, I'll be providing a little bit of a context overview about our hospital and healthcare, which will, again, fit very nicely in with what Jennifer has just said. Talk a little bit about how we have approached it here at Michael Garron Hospital, and then I'll turn it over to Christine to talk about more specific examples of implementing the framework and how we're supporting our workforce with our programs. And then finally, I'll come back on at the end and just talk about some of the outcomes that we've seen here at the hospital. So very briefly, the Michael Garron Hospital is a large community teaching hospital. We serve over 70,000 emerge visits annually and about 3,100 births per year. It's a unique community because of the population that we serve, with lots of new immigrants, high number of visible minorities, very high disability rates, incidence of chronic illness is very high, premature death is also high. We know that the residents that we serve in our catchment area are about 400,000, and as a general hospital, we have all of the services that you'd expect to find at any hospital, with the exception of trauma, cardiac surgery, and neurosurgery. I've been referring to, and you've heard before, how we've actually transitioned from being the Toronto East General Hospital to the Michael Garron Hospital. Very briefly, I just want to tell you a little bit about the story. So that there was a young man, Michael Garron, who was born here at the hospital in 1972. Unfortunately, Michael passed away when he was 13 years old. And his greatest fear when he realized that he was passing away was that he would be forgotten. And his mother made a commitment to him that he would never be forgotten. The family subsequently became very, very wealthy, and they have made a significant financial contribution to the organization, and in that regard, we've changed our name, or in the process of changing our name, to the Michael Garron Hospital. I think Jennifer has touched on some of the challenges in healthcare. Just to reiterate, highlight some again, about 88% of healthcare workers report insomnia, headaches, depression, weight changes, panic attacks related to work stress. 35% of nurses report at least one musculoskeletal condition. 28% of nurses were physically assaulted at work. 48% of physicians report advanced stages of burnout. So that's sort of the environment that we live in. We also know, and you've heard before, that healthcare workers are 1.5 times more likely to be off work. Nurses have high blood pressure, high rates of cardiovascular condition, and high rates of lost time due to injury. So our reality is, shift work, compassion fatigue, physical workload. So recognizing that that is our reality, and recognizing that our workforce is very good about caring for others, but we know that our workforce is also not that great for looking after themselves. And so how have we implemented the standards? How have we tried to improve the situation, given that that is the setting that we work in? And we recognize that what we wanted to do was to improve the performance from a safety culture perspective for our staff, and also obviously want to increase the performance and outcomes for our patients. And so we identified this model from Graham Lowe as one that speaks to how we've been able to implement changes in the organization. If we wanted to improve performance, we recognized we really have to work backwards and work with our staff to make sure that we had higher engagement and also that we had high trust in the organization. And it really starts at the board level. This is a snapshot of our strategic plan that was developed in 2013. And one of the key priorities is to role model excellence in workplace safety, engagement, and wellness. So that's established by our board. When we look at our HR plan, which falls from our strategic plan, you see there in front of you some of the priorities within that, which includes cultivating a healthy work environment and promoting healthy bodies and healthy minds. And then subsequently, although not pictured there, we've also developed a wellness plan as well as a mental wellness plan. And within our mental wellness plan, we've aligned that to the national standards for psychological health and safety in the workplace. And specifically, the areas that we've identified as priorities for us is mental health education and awareness, prevention, management, and positive workplace culture. And if anyone's interested in our mental wellness plan, please email us and we'll make that available for you. We recognize, and Jennifer has already touched on this, the importance of partnerships. So we've had a long-standing partnership with the Excellence Canada, and in fact, we were one of the first hospitals to achieve a platinum recipient for the Mental Health at Work designation. The only other organizations that we're aware of is Bell Canada and the Mental Health Commission of Canada. Other key partners, obviously, Ed Mandler, the Mental Health Commission, and the great work that Sandra has done. Healthcare Can should have a logo there as well because we all obviously work with them, including Jennifer. We're also working with other healthcare providers. So we've established the Joint Centers for Transformative Healthcare Innovation with 5 other community hospitals, and collectively we're looking at how do we reduce workplace violence that affects our staff. Our Solutions Network is a voluntary network of East Toronto health partners, and there we're looking at a systems level about how can we use the resources that we have here to help support our community partners. A little bit about our journey. Obviously started many years, and we don't see this as ending anytime soon. But early on, we developed a mental health strategic plan. So the one I just referred to is probably our 3rd iteration. We've had a long focus, and Christine will speak on this further, for emotional intelligence training. Workplace violence prevention has been another journey we've been on for a very long time. We also do quarterly engagement surveying, and I think Christine will highlight some more of that. Also focused between 2010 and 2012 on adapting and creating a culture of continuous quality improvement and really focusing in on a just culture. We know that things happen in healthcare, things happen in all work environments. How do we support our staff that come in every day and are here to do the very best? We've had a long relationship also with Bell Let's Talk. Looking at the last couple of years, 2013 to 2016, we've been an early adopter of the national standards. As you've heard about the research study, we've been part of that. We've had second victim peer support. Excellence Canada, we've achieved level 3 and 4 in their workplace mental health criteria. We're looking at tracking and scorecarding the work that we're doing to show some of our improvement. We're actually training 25 of our managers in the Queen's Mental Health Training Program. We've had a small group go through it already, and we'll be sending another 25 people through that. And recently, we're rolling out a comprehensive program to support LGBTQ diversity training in the organization. So maybe at this point, I'll ask Christine to speak more about our implementation approach and some of the specific programs.
Thank you, Wolf. So this has been an evolutionary journey for the Michael Garron Hospital, and one that has been supported and sustained by a significant commitment from senior leadership by prioritizing wellness in our corporate strategic plan and by allocating resources so that we are able to build a comprehensive framework for implementation. So in 2010, we developed or adopted the patient-centered care model. And this model is one that is focused on the quality of relationships and the correlation between that quality and the patient experience. So as you can see, the patient sits at the heart of the model, and the slogan that we use throughout the hospital is "Nothing about me without me." So they are an integral part of deciding how care will be implemented in each case. And along the perimeter, we see all of the relationships that interact and influence the patient experience. So how do our healthcare providers relate with each other, colleagues and peers, and how do we interact with patient families and secondary decision makers? You can see in the left side of the slide the provider's relationship with self. So it's our obligation as an organization that we provide an environment and opportunities for skills development to allow people to enhance these relationships. But it's the healthcare provider's responsibility to come to work whole with the ability to apply the best care to our patients. And this is where wellness sits, in the relationship with self. So inadvertently, what we discovered through our journey over the past many years is that we, in fact, reinforce Dr. Lowe's idea of performance links. We looked at the immense risks, or the most prominent risks in our environment, that being physical safety to our frontline staff, addressed those issues. Over the years, our approach has evolved to include psychological health and safety. So we're taking a more holistic approach to wellness in general, and also to comprehensive and legislated health and safety. And what we have found, and we'll fully elaborate on these metrics in a few moments, is that we have experienced increased engagement at a consistent rate over many years, and that has led to higher performance. How did we do it? There's many ingredients for success, and they're not solely the invention of wellness, but rather they're more evident in our processes, in the ways in which we deliver care. And so Lowe indicates in his ingredients for engagement several aspects of or characteristics of the workplace that lend to psychological health and safety. And these are elaborated and also expanded within the National Standard for Psychological Health and Safety. As we've discussed, physical health and safety, psychological health and safety were a major priority and continue to be within the organization, but we also have to ensure that there are many other mechanisms in place to allow our staff to do the best work that they can. So a civil and respectful workplace is one that is supported by policy and practice. There's a standard of behavior, there are team agreements and a code of conduct that is upheld within the organization. There's many opportunities for two-way communication. So we round on units and in teams. We have huddle meetings every morning in the hospital at the start of shifts. So probably around 8:05 in the hospital every day, there's roughly 80 teams that are having a huddle, discussing the objectives for the day, any new communications that come down through the organization that pertain to new procedures, new policies. We also have open forums where our senior team holds town halls where staff can ask questions about many aspects of life here in the hospital, and we hold focus groups. So we include our staff in the creation of new strategic plans, of new visions and mission statements as well. Autonomy and input. So we trust the real experts to do the work, to do it well, and to also show impetus to improve the way the work is carried out. Adequate resources, always a struggle in healthcare, and therefore greater impetus to build sustainable staff supports. Supportive supervisors. So are our supervisors willing to jump in and assist during demanding or emotionally challenging work? And is work challenging? Does it breed innovation, passion, drive in our people? And do we provide the right amount of recognition and reward our folks for the job that they do. So we have several reward programs within the organization that range from daily shout-outs at huddles for a job well done or a great new idea to a more formalized awards program like our long service awards. All of these ingredients, all of these mechanisms are surveyed in our engagement surveying. So we ask questions to know whether or not we're achieving what we want to. And what it does, what each of these characteristics do, is it allows and lends a sense of ownership and accountability to staff. They become part of the process, part of the creation of the way we deliver care. So as Wolf mentioned, we do engagement surveying here, and indeed our wellness program was actually born out of our first engagement survey from 2004, which showed quite low trust scores in the organization. And so in order to make a commitment, a visible and sustainable commitment to our staff, we started our physical wellness program. To tell you a little bit about the process of how we apply results, when results come in, I should tell you that we do this quarterly and that the hospital is divided into 4 cohorts. Each cohort is surveyed once a year. And so when results come in, there is a meeting between unit managers, an HR generalist, and the senior leadership responsible for that program. And key priorities are highlighted. These priorities are taken back to the unit teams, and in unit-based councils, the teams are then responsible for developing an action plan, which is then monitored over the course of the year, and we measure impact of change. So we've had the great pleasure of participating in the Mental Health Commission's research case study project, and that has given us the very valuable experience of talking with other healthcare organizations to understand that the challenges are the same for all of us. We have a rapid rate of change that we are constantly dealing with. We have competing priorities and limited resources. And so each organization, we've learned, has assessed along the way what have they started with and have built their foundation for implementation on programs that already have existed, as did we. So we had several programs in place and a few that have developed and been enhanced over the years. So our first one is emotional intelligence. And this really helps to reinforce the patient-centered care model and help staff develop the skills necessary to enhance relationships and improve the quality of care we offer. Mandatory EI training is part of our organizational orientation. Every new hire receives 4 hours of training, which is focused on fostering the ability to recognize, understand, and manage our own emotions, so that we can recognize, understand, and influence the emotions of others. It's built around a competency model that recognizes that when people are given the opportunity to establish and practice self-awareness and the skills to manage their own emotions, they can then build emotional connections and empathy with people. And this is the foundation that allows people to strive for personal leadership. Everyone in the organization, new hire, senior leadership, management, and supervisor have all undergone this training, and our senior team managers and supervisors have gone through a comprehensive one-day course, complete with a 360 evaluation. We've extended our training from our general emotional intelligence programming to include the 3 conversations of leadership performing under pressure. We launched this program last year, and basically it's a focus on 3 different types of conversations and how environment and organizational pressures can affect our ability to be effective leaders. So we have high-impact daily conversations that set up a really strong foundation of trust, so that when we have to have difficult or courageous conversations with people within the organization under highly pressurized conditions, we can identify emotional risks and then practice strategies to offer or address feedback that is often left unsaid when we are addressing important issues. Our workplace violence prevention program started in 2008 in response to a few significant incidences that had happened that year within the hospital. There was also coincided with an ONA study that showed 54% of nurses experienced physical violence in the last 12 months of work, and 85% of nurses had experienced verbal abuse. In the year 2013, WSIB reported 639 lost time claims due to workplace violence. So this was a call to action for us to ensure the physical safety of our staff. And so we went about developing strategic partnerships with our senior team, our ONA representatives, HR, our mental health crisis intervention team, and the Ministry of Labor. We underwent an extensive environmental assessment and developed a procedure where we could take apart critical incidences or violent incidences that have been reported and develop an analysis for root cause. We enhanced our organizational supports with EAP, on-site counselors, a formal debriefing protocol, and a comprehensive return-to-work program. We also require every staff member to undergo violence in the workplace training. There is an e-learning component, and there's also an in-class component that is comprised of de-escalation techniques and physical intervention techniques. As far as the environment is concerned, we put a lot of extra resources into enhancing security. So there are extra cameras. We use the Vocera communications system within the hospital, which is a personalized device with a panic button that can allow staff to speak with security with the tap of a button. And we have a comprehensive patient flagging system that allows staff to understand that they may be walking into a room where a patient has displayed aggressive behavior. So what we have found, and we track these incidences closely, is that in 2011, we reported 256 of these violent incidences, and in 2015, we had experienced 303 violent incidences. We appreciate that normally we like to see numbers go down on a graph, but we like to view this as a success story in terms of shifting culture, making it okay to report these incidences. They were happening before 2011, to be sure, and now that we see that the numbers are going up, we're very appreciative of the fact that we've created an environment where staff feel comfortable coming forward and that they know this is not an expectation of what is required to do their job. Violence is not a part of healthcare. So our code white. A code white is called in the event of a violent situation or a threat of violence. It can also be due to a physically aggressive outburst or an out-of-control individual. And so we call a code white, and we look at number of incidences that are recorded yearly. And again, we can see a rise in the number. So from 2010, we had 55 reported, and in 2015, we had 91 reported. So just taking a look at a couple of programs that we deliver at the unit level, our compassion fatigue program has been in existence for quite a few years, was revamped and enhanced probably 2 years ago. And it is not only to create awareness about what is compassion fatigue, but also to fight the stigma that exists in nursing and healthcare, where a lot of healthcare professionals would like to see the young up-and-comers toughen up. And so we really like to deliver this form of education to folks to allow them to validate feelings that they may have about caregiving and to recognize that compassion fatigue is a normal and natural consequence of doing your job well. So for those of you who haven't heard of compassion fatigue, it is a deep physical and emotional exhaustion. It's an erosion of our compassion, of our ability to empathize, to tolerate strong emotions or difficult stories in others. All first responders, healthcare workers, and caregivers are at risk of developing some degree of compassion fatigue. symptoms can often resemble PTSD or depression, and are most often, the symptoms are evident in the healthcare provider's personal and professional life. We consider it an occupational hazard, and therefore we teach and train at the unit level about the existence and the reality of compassion fatigue. So what are the warning signs? We offer debriefing training to minimize secondary and vicarious trauma, and we also put into practice stress reduction techniques. This allows the healthcare provider to understand that their experience is normal and that they are not alone. Our second victim peer support program is alive and well in our emergency department and has been for a few years. It's a formalized way for us to care for each other immediately following a critical incident. And it was the result of and came out of an event that happened in our emergency department several years ago, where on a Christmas Eve, a mom and a baby a mom who was expecting a baby came into the emergency department, and we lost them both. And so that really shook our team to the core, and we decided that in addition to the regular supports that we call in externally, that we needed to have an immediate response. So we did extensive research about second victim syndrome, and we also surveyed our staff to discover what their needs are, what are their core wants after a critical incident. And so how the program works today is charge nurses come in and they check our daily triage reports early in the morning, and they look for out-of-the-ordinary cases. So we know that our emergency room staff are very comfortable with end of life when it's an elderly person who has clearly lived a full life and is surrounded by loved ones at the end. They are not comfortable with the unexpected, unpredictable, severe outcomes. So we look for those incidences, and then our charge nurses then check in with everybody. They round with the entire team, they give them a timeout if they need to, and then they show they care. We know that care providers doubt their skills after a critical incident, so it's for us about reinforcing that we still have confidence in their skills, that their peers still respect and support them, and that the individual is still a trusted and valued part of the team. So our mental health first aid program is facilitated by two of our nurses with the Mental Health Crisis Intervention Team. It is a program that is run through the Mental Health Commission, and it's basically first aid provided to people who are either developing a mental health problem or experiencing a mental health crisis. And what we have found, the feedback has been extraordinarily positive from our frontline caregivers, who now feel very confident in approaching patients who may be in need of extra support. Our diversity training began in the spring of 2015 as our first step in building an inclusive environment at the hospital. This teaching was developed in partnership with the 519 Community Center, and the teaching aims to challenge homophobic and transphobic language and behavior, and to build the capacity to foster a safe and LGBTQ inclusive environment for all of our employees, our patients, and all visitors to the hospital environment. We want to also develop measurable actions to foster a safe and LGBTQ inclusive environment that protects the dignity of all those in the LGBTQ communities. And so just one last little tidbit. We do go out to huddles. We try to go almost every day to a different huddle to fit in a little bit of practice, because it's easy to preach, but it's better received if you are walking the walk. And so we do get out to huddles and communicate our message to our teams. And so I'll hand it over to Wolf to tell you how far we have come.
Thank you, Christine. So just a few more slides. First of all, we've talked a little bit about staff engagement. So we've been doing this on an annual basis or every other year for a number of years, and we continue to show engagement scores that are increasing and that are over the OHA, the Ontario Hospital Association average. When we look at some of the specific questions that are important to us, organization promotes health and wellness, balance with family, personal life with work, and can trust the organization. We've seen that the work we're doing is paying off. We've seen continuous improvement, slight dip in some of the scores in 2015. So as I said, it's a journey, it's never done, and we need to continue to try different programs, different ideas as we implement the psychological standards. And we're still proud of these scores because we are still above the OHA average scores. When we look at average absence days, again, we're below the OHA average, and that was not the situation a number of years ago. When we look specifically at our health benefits analysis, we've seen that our annual cost for long-term disability for psychological conditions has come down in 2015, so that's one of the measures we continuously look at. Also, the annual psychological drug costs, we've seen a decrease in 2015. And why do we do all this work? I mean, I mentioned before, we certainly want to make sure that we have provided the very best work environment for our staff, but ultimately, the work that we do here at the hospital is to make sure that we're providing the best and safest care to our patients. So we're also looking at what are the outcomes for our patients. So we've seen improvements in ED satisfaction, as an example. Our ED wait times have gone down. Infection rates or hand hygiene compliance have improved. Patient satisfaction for inpatients, our mortality rates, all of these indicators are heading in the right direction, which helps us validate that the work we're doing. Also, other quality metrics, such as falls with harms or in-hospital sepsis. So briefly, I'm going to ask Christine just to talk a little bit about some of the work that we have currently underway and some of our new plans.
Thanks, Wolf. So we have signed on for an additional year to work with the Mental Health Commission of Canada with the Sustainability Case Study Research Project. We're very happy to be a part of that. We are developing a new comprehensive bullying in the workplace curriculum, and we are looking at best practice for staff supports in medical aid in dying. So how do we support staff and create a resilient environment for those who are participating and for those who are conscientious objectors? How do we support them as well? We are also spreading the Second Victim Peer Support Program to other units, and we'll be working with our security department to understand better what some of the supports that they may need. This work continues to evolve. It has truly become a part of the decision-making process at Michael Garron Hospital, and we commit to continually messaging the importance of psychological health and safety to our staff and to fight stigma surrounding mental health in the workplace. It is a standard that blends easily, or the national standard is one that blends easily with quality workplace and continuous improvement initiatives, and ultimately, it's an opportunity for us to shift organizational culture. And so with that, we'll turn it over to Sandra.
Great. Thank you so much, Wolf and Christine. We certainly are very proud of all the work that you're doing, and also very grateful that you're able to, share your story and hopefully motivate other organizations to follow suit and, learn from you and other organizations that really are advancing. And I guess trailblazers is often a word I like to use to describe your organization and your work. So congratulations. And with you as well as Jennifer, definitely proud on behalf of the Commission to work with you all and continue to do so moving forward. So before we go to fielding a couple of questions, I did want to point out that we have a number of resources related to this topic. Hopefully a lot of you have already downloaded the standard, but if not, you can do so free of charge through the CSA, Canadian Standards Association website. And we also have an implementation guide to further help you at least hopefully get started and understand some of these pieces that relate to what you've heard about today. I won't go through them all, but they are here for you. I did also want to point out that a lot of people have been asking about access to these slides. So we do have a webinar archive where you can access actually all previous webinars from the past, I think it's almost 3 years now. including this one. It does take a few weeks for us to be able to finalize and upload them, so do have some patience with that. But also, Wolf and Christine, I wanted to point out that there have been a number of requests for access to your mental health and wellness plan. So I just wanted to let you know about that. And is there a way that we can perhaps share that in whole or in part with a larger group?
Yes, if they just would like to email us, we'd be happy to send them a copy for sure.
Wonderful. And we will be putting your contact information up at the end, so we will be sure to do that. And again, to all participants, that will be available within the slide deck as well, and you can also connect with the commission if you're having some issues there. So Tina Corey is our wonderful point person, so feel free to ask and we will field through on that as we can. Okay, great. So let's just get to a few questions that we have. One here is, I think this is a great one for you, Wolf and Christine, is what is the single most important change that you think can be made in the workplace related to this area? And ideally that would also have the biggest impact. Now I know that might be a bit of a, you know, a challenge to answer, but you know, just from your perspective anyways, what would you recommend maybe for an emerging organization?
Maybe I'll start, and Christine might have a different perspective, but I think just start. You know, just get started. It doesn't necessarily matter what program you start with first or if you have a plan or not. I think the commitment from leadership is important, but you may not have that, and you just may need to start with some programs, and it builds over time. It's a long journey, and I don't think that there is one roadmap for every organization.
Right, and if I could add, in the standard, in Annex E is a really great assessment tool, which we undertook at the beginning of our journey, and it gives you a great way of cataloging what you already have in existence, and I think many organizations will be surprised to find that they have already several mechanisms, policies, practices, programs that fit the psychological standard. And then you just go about messaging, communicating this to frontline staff, and to enhancing what is already there. That's a great starting point.
Wonderful. Another question we have for you, Wolf and Christine, is related to your staff engagement survey. There was a slide you had specific to that process, but we did get a question about, like, what survey did you use? Was there a specific one that you had access to and used, or was it sort of a hybrid of a few different sources?
So we partner with NRCC Picker. I get that wrong every time. And it is a survey that most hospitals in the OHA participate in, so we can compare ourselves to others in our field. There are over 100 questions, some of which we have the ability to tailor to our needs, most of which are designed around several themes. So there's a job theme, a health and safety theme, a leadership, training and development theme, and we can pull specific data from each of those areas.
Great, and so just quickly in follow-up to that too, was there any sort of tips or tricks you have related to the participation of doing this type of survey? In terms of, I guess, you know, any kind of motivation or incentive?
We don't offer incentives, but what we do is very clearly and with a great amount of effort and care is communicate back to people how they have changed the way we do business here.
Yes, I'll just add that if staff see us acting on it, they'll be more than willing to participate again. If we're not acting on the previous survey, they'll just say, why bother? So we make a point of acting on the results by department, by unit, and then reminding staff before they fill out the next survey, here's what's changed because of feedback, both from an organizational perspective and also within your unit.
And what we've found is that over the past few years, our response rate has actually increased. So the messaging seems to be doing the trick.
Wonderful. That's great. So that's all the time we have for questions today, but I do want to thank you again so much, Wolf and Christine, as well as you, Jennifer, for participating in today's webinars. We do host them, as most of you know, and we're happy to have a lot of regular followers. We do have these free webinars every month, except we are taking a bit of a summer hiatus. So for July and August, we will be regrouping and coming up with a great next series starting in September. And I do want to just take a quick moment to thank my colleague Tina Corey, who does manage these webinars. And of course, I like to say it does take a village to make these things happen. And so we also have a lot of wonderful support from Benita and Catherine, who have been helping us throughout this journey of ours. And so with that, stay tuned for September. And we just also want a friendly reminder that when you do log out of this webinar, that there is a survey to complete, and we do really look at your feedback in terms of ideas to how we can improve and perhaps offer suggestions for upcoming topics or things that you'd like to learn more about. So thank you so much to everyone for joining the call today. It's been a great series up till now, and we hope everyone enjoys the summer as well. Thank you.